Okay, well, that's our cue to get started. So if you've not taken a minute, please put your name and contact information into the chat. Welcome to today's Echo session. We are recording today's session. We store that on our Canvas page as well as on our YouTube channel. So if you ever want to go back and review what we've talked about or share the recordings with any coworkers, please feel free to do that. If Echo is an interactive community, so if you feel comfortable and you will be willing to, please turn on your camera. It helps us see who's on the call, get to know each other. Doing all these things virtual, we miss that face-to-face, so the cameras on Zoom help us to do that. Please ask any questions or provide any comments into the chat. So we want you to be interactive. And then again, also that case narratives are a great way to get valuable resources from everybody on this call. So if you're interested in doing a case presentation or a case discussion, please reach out to Time to Act at aggies.usu.edu, and we'll get that going. A lot of things, and especially today, is a sensitive topic. So please take a minute for yourself, but also remember to protect individual privacy. So don't share information that others would be able to identify. If you have any questions about what to share and what not to share, feel free to reach out to one of our amazing hub members. They all have an asterisk, or will now have an asterisk in front of their name, so you can easily identify them. They will also have a screen similar to mine in their background. Key components of an Echo session, if you've ever been to one, you know what that is, but if not, welcome to today's, your first Echo session for today. We always will have a didactic speaker, and then we do a case presentation and a discussion. So during those discussions, we break into small breakout groups to be able to manage that a little bit better, and to have everybody give an opportunity to talk about their perspective of the case. It is a great opportunity, again, to learn from all the amazing people on the call, as well as to hear new and useful resources that can be shared with multiple families or clients that you're working with. So sometimes our cases match what are being discussed, and sometimes it's just a whole family complex that is dealing with some mental health. So please don't feel that your case, if it doesn't match our topic, you can't do it, because it is still a valuable way to gather that information from everybody on this call. Please take a minute, and there's a thing on my screen, I couldn't move past it. To rename your profile, tell us what your discipline is, where you're from. Again, that really just kind of helps get us connected with each other, even though we are over Zoom. We've all been on Zoom for quite a few years now and probably know how to raise our hand, but in case we don't, here is how you can raise your hand, but feel free to just put any information or comments into chat. Kurt Phillips will help monitor that for us, and we'll make sure your questions get asked.
Roses.
Again, please, if you want to, pre-register for all of our Echo sessions. It allows you to get information. When we have PowerPoints, we try to send those ahead of time. Today's PowerPoint will not be available. It's a copyrighted one, so it will not be stored anywhere other than on our recording. In order to get a certificate of attendance, we do ask that you fill out the survey. Those surveys help us share information to our funding to be able to keep these professional development training's free, so please take a minute and complete those surveys. They will be dropped in throughout today's session, as well as in a follow-up email after today's session. Canvas is where we store everything. And again, just another plug to do a case study if you're interested in doing that. I can't tell you the amazing things that everybody on this call comes up with to be able to share with families or clients that we're working with. Sometimes it might be a little nerve-wracking to do that and present your case. But if you're interested in doing a case, please just reach out to us. I would be more than happy to be the one who presents the case for you and walk that through everybody. Because like I said, those cases, the recommendations and resources that you get are so valuable and helpful. So thank you to everybody on the call that provides their knowledge and sharing that. And that's really what ECHO is all about, is sharing the wealth of knowledge with everybody. I don't know everything, and Jen Morgan doesn't know everything, but man, we know something. So being able to share that and know that with everybody. Again, we do have social media that we share useful and valuable resources that we get throughout the month from presenters, from other people within our network. So take a minute and follow us on social media. Again, today I'm really thrilled to introduce Jeannie and Tara that are from the Brigham
Trauma training?
Suicide Prevention. We are
Suicide. It's about suicide.
Oh, someone's not
It's,
mute. I'm gonna mute everybody. I know that today's topic can be a sensitive one, and they will probably go into some ways, but feel free if you need to take a minute for yourself to take that minute. I'm going to stop sharing and turn the time over to Jeannie and Tara.
Okay.
There we go.
To get everything ready. All right, everybody can see my screen.
Yes, thank you.
Perfect. Yeah, absolutely. All right, so yeah, I will remind everybody that this is a sensitive topic, and we understand that sometimes it can be difficult to hear some of the information that will be imparted. So if you do need to take a moment, please feel free to do so. If you also need help after you have experienced that discomfort, please reach out to one of your many colleagues. You're lucky to have many, many choices. So thank you for attending today's presentation. I appreciate it. Again, my name is Tara Roche. I'm the chair of Brigham Suicide Prevention and the co-chair of the Northern Utah Out of the Darkness Walk for the American Foundation for Suicide Prevention. And my colleague Jeannie Peck is also joining us today. And the presentation that we're going to go over today is called Talk Saves Lives. It's an introduction to suicide prevention. I know that suicide can be a sensitive topic to discuss, but talking about suicide is critical to its prevention, and we are grateful that you have joined us to have this important conversation. So suicide is a complex health issue, but it is a health issue. Suicide can also be prevented despite its complexity. Just like there are warning signs and risk factors for other health crises like cardiac arrest, we can learn the warning signs and risk factors that can help us to prevent people from dying by suicide. As with other health issues, prevention can start early, far in advance of the problem, or prevention can occur closer to the time of the crisis. Time can be a critical and life-saving measure. Typically, a life can be saved if you allow time for the person's suicide risk to subside or to get through that period of distress and to get mental health help. To prevent suicide, we need to identify persons who may be suicidal, as well as take an active role in connecting them to help before they take action to end their lives. The purpose of Talk Saves Lives is to provide community members with a general overview about suicide, who it affects, and what can be done to prevent it. This presentation will cover some statistics to give you an idea of the scope of the problem of suicide. We'll also review some key research findings, including the risk and protective factors that relate to suicide. And then Jeannie will then speak with you about what works and what we can all do to prevent this leading cause of death. How we talk about suicide matters. Before we get started, I want to go over terminology that's used when we talk about suicide. It's important to model appropriate language so that we do not perpetuate the stigma surrounding suicide or mental health conditions. So these are some of the language do's and don'ts, and we want to establish a baseline of shared language on the topic. So we now avoid using the phrase committed suicide as it can have a negative connotation. Instead, we encourage the phrases died by suicide, ended their life, or killed themselves. When talking about suicide and suicide attempts, we also want to avoid referring to suicide attempts as failed or successful. Not only is it unnecessary, but they also imply judgment, and they're obviously also the opposite of what we want people to view a suicide attempt as. When they've failed, they're alive, and that's a positive. And so we don't want to add the connotation that it's a positive if you've succeeded and a negative if you've failed, when that is the exact opposite of how we actually feel. And instead, we encourage the use of phrases such as suicide attempt, just suicide, or death by suicide. Educating the public about suicide is critical for encouraging help seeking, raising awareness of risk in vulnerable populations, and advocating for new interventions and prevention strategies for those at risk. And when suicide is talked about safely and accurately, we can help reduce the likelihood of its occurrence. And we want to change how society understands mental health and suicide, because when we open up and connect, talk saves lives. So looking at the scope of the problem, suicide is a significant issue that affects individuals, families, and communities worldwide. So we're going to start with some statistics that demonstrate the scope of that problem. Suicide is a global problem. According to the World Health Organization, each year over 800,000 people die by suicide worldwide. And while this is the most accurate data available, we also estimate the numbers are quite a bit higher, since suicide is underreported in many countries, and oftentimes without clear-cut obvious signs that a suicide has occurred, they may not be classified that way either, even in countries that do have accurate reporting. This works out to a suicide every 40 seconds worldwide. In the United States, suicides rates are recorded by the Centers for Disease Control and Prevention. And according to the CDC, in 2021, there were 48,183 people who died by suicide. This is the most recent data available, though we do expect 2022's numbers to be coming out fairly soon. There is an increase in our numbers for 2022, but we returned more to what we expect for 2023, just as a little heads up. This makes suicide the 9th leading cause of death. Suicide takes more lives in the US than homicide, war, and natural disasters combined. These numbers are one of the many reasons that it's important to talk about suicide like any other cause of death. The more we talk, the less stigmatized the idea that we will all face struggles and need support sometimes becomes. And then for every death by suicide, it's estimated that 25 others attempt. So that's about 1 million Americans each year who survive a suicide attempt. These numbers also are likely low when somebody has made an attempt and survives with no ill effects. They typically won't seek medical care, nor will they share with someone. So we may be underestimating these numbers as well. So when we normalize the suicide rate into per population numbers of per 100,000, and these numbers are from 2020 because that's the most recent I have in the prepared slides. But in 2020, suicide rates were higher among adults aged 25 to 34 years old than they were in 2019. Younger age groups have had consistently lower suicide rates than middle-aged and older adults, though their rates have steadily increased since 2013. In 2020, adolescents and young adults aged 15 to 24 had a suicide rate of 14.24. Many of you have probably also noticed, though, that oftentimes our youth suicides receive a lot of attention, and it almost detracts from the groups that we see struggle the most. It's another reason why talking about how it can impact all ages and demographics is important. When we look at rates of suicide by race, ethnicity, and gender, you'll note that rates of suicide in females are lower across all races and ethnicities. As I mentioned before, overall rates of suicide in the US decreased slightly between 2019 and 2020. However, suicide rates among Black males, Black females, as well as Native Americans and Alaskan Native males increased between 2019 and 2020. Note that the Center for Disease Control and Prevention records Hispanic origins separately from the primary racial or ethnic groups of white, Black, American Indian, or Alaskan Native, and Asian or Pacific Islander, because some of these individuals will, in all groups, will also be Hispanic. Overall, across groups, the rate of suicide for non-Hispanic people was 14.66, and the rate for Hispanic people was 7.52 per 100,000. Half of all suicides involve firearms in the United States. In some states, firearms are used in as many as 70% of suicides. For Utah in 2021, that number was 57%. While there are several factors that impact the number of firearm suicides in the US, one thing's clear. If we can connect those who are struggling to help before they reach for a firearm, we can save lives. Most people who buy a firearm don't realize that there's a link between having a firearm in the home and death by suicide. So like that is all that's necessary to increase suicide risk, just having a gun present, no matter how well stored it is. And of course, storage is key. And it's critically important that firearms be educated in suicide prevention and secure storage. Most firearm deaths in the United States are suicides. About 2/3 of all firearm deaths in the United States are suicides. For 2021 in the state of Utah, that number was 81%.
And Tara, we can also tell them if anyone needs a gun lock.
Yep, absolutely. We have gun locks and access to gun locks. So please reach out if you'd like to get some. So suicide does impact individuals and communities, just like with any loss, right? So suicide's no different than other losses. The loss affects family, friends, coworkers, neighbors, schools, faith communities, and nobody is truly protected and safe from that. It's estimated, in fact, that the majority of Americans will experience a suicide loss over the course of their lifetime. So I next want to talk a little bit about the Utah numbers. So it was the 9th leading cause of death in Utah in 2021, just like it was for the overall nation. It was the 2nd leading cause of death for ages 10 to 24 and for ages 25 to 34. And this was a positive change from its #1 status for many years on those two age groups. It is also the 2nd leading cause of death for 2021 for ages 35 to 44, 5th for ages 45 to 54, 9th for 55 to 64, and 18th for 65 plus. Nationally, again, we lost 48,183 people to suicide. 643 of those people were Utahns. That gives us a national rate of 14.04, but a Utah rate of 20.09 per 100,000 per population. And that did give us a state rank of 14, which dropped us for the first time out of the top 10 for many years. So that was excellent news to see. But again, the more important information, of course, that we want to highlight is that we need to bring this number down and this number down. This number is not as important, right? So again, I'll remind you, 81% of firearm deaths were suicides in the state of Utah. 57% of all suicides were by firearm. People were over 8 times as many people died by suicide than in alcohol-related motor vehicle accidents. But we talk about why driving under the influence is important. Not driving under the influence is important all the time, but suicide does not get the same attention, despite having such a loss of life. And in fact, total deaths to suicide reflected a total of 15,372 years of potential life lost before the age of 65 when using Utah's numbers in 2021. All right, so next I want to talk a little bit about the research. So really only in the past several decades have scientists been studying suicide. Research is shedding light on many critical areas, what drives up risk and what that amounts to effective suicide prevention. And we still have more to learn, a lot more to learn. We still don't know as much about the human brain as we would like to. So there's a lot of information that we can still come up with. This section provides an overview of suicide prevention research, key research findings, and future goals in the field. I'd just like to point out that the American Foundation for Suicide Prevention is actually the largest private funder of suicide prevention research in our country. So we're lucky to have them, and all the research that they have helped fund has given us this information. So one of the main questions research explores is why? Why do people take their own lives? Through research, we've learned that there's no single cause for suicide. Suicide most often occurs when several stressors and health issues converge to create an experience of hopelessness and despair. So there are many intersecting factors. Research has consistently shown that the large majority of people who die by suicide have a mental health condition at the time of their death. It may or may not have been recognized by the person or their loved ones, may not have been diagnosed or adequately treated. That said, research has also made clear that mental health conditions cannot be the whole story. The vast majority of people who have these health conditions do not go on to die by suicide. So 1 in 4 people will experience a mental health condition, and yet do not go on to die by suicide. So we know there are physical differences. So in addition to those mental health conditions, there are other factors that increase risk as well. Some of those are like physical differences. We've learned that the brains of people who die by suicide differ from those who die from other causes in terms of structure and function. And this is specifically true in the areas related to stress response and impulse control. Most people who are suicidal are ambivalent about taking their lives. This is one of the most important things that they've learned through research. Most people are ambivalent. Part of them wants to live, part of them wants to die. This research has informed key strategies in suicide prevention that involve engaging the part of the person that wants to stay alive and helping to create distance from the part of them that wants to die. One way that we do that is to connect the person with reasons for living while at the same time decreasing the visibility and presence of things around them that may facilitate their desire to die. And now, one of the many important things that we've learned is the perspective of a suicidal person. That a crisis point has been reached. For a suicidal person, the pain seems unbearable, whether it's emotional pain, physical pain, or sometimes both. For a moment, I want you to think back to the most physically painful experience of your life. At that moment, do you think you would have been able to give clear and accurate directions to your house? Yeah, probably not, right? That pain makes ordinary thinking nearly impossible. So for a suicidal person, thinking becomes constricted at that moment of crisis. It's a state of intense tunnel vision where other options just seem unavailable. Someone who considers suicide cannot foresee a time when that unbearable pain will end. Understanding the perspective of the suicidal person has also helped us to learn that suicidal feelings are often temporary. They can come on intensely and can sometimes pass in minutes or hours, but keeping people safe and helping them feel supported can get them through those critical moments. There's evidence that putting time and distance between an individual who's suicidal and the means to take their life can be a life-saving action. This is why it is so important that we take steps when we know someone is struggling to help keep them safe. And I hope that all of you have noticed that we have a lovely program here in Utah, the Live On program, and we have billboards talking about this kind of thing and how we can help so easily to remove means from people and help protect them. It doesn't, like, people think that preventing suicide takes a lot of effort, and it really doesn't actually. Just being there and helping to remove means are both hugely important, for instance. So let's talk about who's at risk next. Research has helped to determine the key factors that increase the risk for suicide. Now, those risk factors are defined as characteristics or conditions that increase the chance a person may take their life. Risk factors are important to know to understand the big picture of someone who's considering suicide. Just like someone who is at risk for heart disease because of high blood pressure or history of heart disease in the family, there are some people that are at higher risk for suicide than others. The main risk factors, which are shown here, can be grouped into 3 categories. We have health factors, and then there's historical and environmental factors. These risk factors can converge at different times in life and increase a person's risk for suicidal behavior at particular points in time. So we're going to dive into each of them specifically and look a little closer. So starting first with health factors, the first type of risk factors are health factors such as biological and psychological medical conditions, the most significant of which are mental health conditions. As we said before, most people who die by suicide have an active mental health problem at the time of their death. Depression is the most common mental health condition and the one that's most associated with suicide. Bipolar disorder is also shown to be high risk, although the disorder is less common than depression. But because these conditions put a person at greater risk for suicide, detecting the presence of a mental health condition is critically important. The best way to be sure when you feel concerned or detect a possible change in you or your loved one's mental health is for the person at risk to seek a professional evaluation and effective treatment. Okay. Many people may not realize that their distress has actually become a health problem. Especially when you're like leading up to it slowly and you are becoming acclimated to the way things are, you may not notice as quickly that there's a problem. So providing information on how to access mental health care or crisis number can be a solid step in helping connect people to the help they need. And we are going to talk more about this later in the discussion when Jeannie directly addresses prevention. I would also like to point out, though, that some of these health factors that people don't necessarily consider is eating disorders. So eating disorders are a huge health factor when it comes to suicide risk. And in fact, their numbers are very similar to depression. So just something to be aware of that many people don't think of. I think personality disorders, psychosis, PTSD, substance use disorders, all things that people anticipate and are understanding can have a contribution, but eating disorders are often missed as a contributing factor. There are other health factors that can play a role, such as serious or chronic health conditions, especially when the person also has a mental health issue. And then we also know that chronic pain and serious head injuries, especially multiple serious head injuries, have been found to increase suicide risk. Okay, some of the other factors that can affect suicide risk are historical factors, such as family history of suicide, a family history of mental health conditions, or a past trauma, such as sexual abuse or combat stress. Research has also found that a history of childhood abuse can contribute to suicide risk. So looking at somebody's ACE and their adverse childhood experiences can be incredibly important to helping to prevent suicide. And while most people who attempt suicide do not go on to die by suicide, previous suicide attempts are also considered an historical risk factor and can put a person at increased risk. And then also the loss of a loved one recently, you are at increased risk to die by suicide yourself if you have recently lost a loved one to suicide. Some of the other environmental factors, so one of the other types of factors are environmental factors. They, of course, involve the circumstances of a person's life. So often there are aspects of a person's environment that can contribute to their overall level of risk. So we're going to look at a few of the most common. Having access to a way of killing oneself is referred to as access to lethal means. This includes having access to a variety of things, so firearms, drugs, a bridge, a car. And research has also shown that contagion, so this is the exposure to another person's suicide or to graphic or sensationalized accounts of suicide, especially among those who already have other risk factors, can increase a person's risk of suicide. It's one of the main reasons why safe messaging and the way that media in particular talks about suicide and suicide prevention is so important. And then prolonged stress may also increase your risk, and it includes things like harassment, bullying, relationship problems, legal problems, unemployment. A lot of the things that make life stressful can also cause it to be a long-term stress. Then there's also stressful life events, which vary across the lifespan, but include experiences like divorce, legal problems, or job loss. And a lot of people don't think about how impactful losing one's job can be, especially if you identify highly with the job that you have. Losing your job can be a huge risk factor all by itself. So to better understand suicide risk, here's an example of a set of risk factors that could converge in a person who's suicidal. So what people see is this sad experience that has happened, but they can't see the other factors that may come into play. So this example shows that what's often the public perception of suicide When someone dies by suicide, often the story only talks about the environmental factors. This is another place where media could do better. But they often talk about that environmental factor, and people see a life event like a breakup or bullying or a job loss, and then they see the person die by suicide. So they assume the person killed themselves because of that stressful life event. But that's never the full story. What others don't know is that that person who died may have had genetic risk for suicide. Maybe they were suffering from depression and anxiety disorders, and their work life had become increasingly stressful. The underlying depression and anxiety could have made the situation at work even worse, or the work stress could have made their depression worse, right? So there, it can go both ways, and in fact, it can often be a negative feedback loop where as you're more stressed, you're more depressed, and as you're more stressed, you're more as you're more depressed, you're more stressed at work. I mean, they can often feed off one another. And then, of course, perhaps they've also been drinking more than usual. The key is that the combination of risk factors could have contributed to the suicide death. Therefore, while a life event can play a precipitating role for suicidal behavior, without underlying risk factors, life events alone are not thought to cause suicide. It's one of the reasons why you'll never hear me, for instance, say that bullying caused somebody to die by suicide. It's never that simple. There's always more to the story than that. So the importance of research looking to the future is your research is going to help us find the best ways to fight suicide. Research is looking for biomarkers. So for example, something testable in a blood sample that would help us to identify those at risk. And then there are a number of clinical treatments like particular types of therapy that may be more effective for suicidal people and need to be more studied and developed and built up. The good news is that through research, though, we're learning more and more about what helps those who are in suicidal crisis every day. Research can also help us to identify the most effective programs and interventions to reduce suicide rates and to reduce risk in those who are suffering from mental health conditions. I'm now going to turn the time over to Jeannie so that she can look at preventative measures and how you can help.
Okay, so we've kind of talked a little bit about what's going on, what the research says, but now let's kind of talk about the prevention. We're going to discuss the difference between, or the different types of prevention or protective factors that we can focus on, the importance of engaging in self-care, and the need to provide support for suicide loss survivors and those with lived experience, and the critical prevention strategy of limiting access to lethal means. And you'll find that we say that quite a bit. Lethal means are a big concern. So just like there are risk factors, we have protective factors. And some of these protective factors are here on the screen. We need to make an effort to get healthier, and you protect yourself. More on this in a moment. We'll talk about that. But feeling connected to family and community support can protect us against suicide. When someone is struggling with depression, anxiety, psychosis, substance abuse, these protective factors that may normally be strong can erode and temporarily cause some weakness in our behavior. And so that when that happens, it's important to have family and friends remind us that we can't, to be a protective factor, that they play a big part in our lives. Problem-solving skills also help. Life can get really tough, but being able to see our way through those problems can be a protective factor. And cultural and religious beliefs that encourage connecting and help seeking. And they discourage suicidal behavior or create a strong sense of purpose that can also be a protective factor. Again, note that these are possible protective factors. On the next slide, we're going to kind of talk about mental health care. You want to move this slide?
Yeah, it didn't want to click. There you go.
Okay. Mental health care is an important ingredient for preventing suicide, and we're going to focus on this topic for just a few minutes. Getting effective treatment for mental health conditions like depression, like anxiety, can prevent suicide. But we also need a culture, next slide, where everyone knows. Critical to suicide prevention is getting people connected to mental health treatment. And sometimes that's really hard, especially here in rural Utah. I don't know where everybody lives, but I know in rural Utah it's very hard. One of the biggest challenges is getting people to address their mental health in the same way that they address their physical health. And even physical health, some people have a hesitation. And when people are having a mental health condition, less than half of them usually seek treatment. One way to encourage individuals to seek help for their mental health condition is to treat mental health like any other aspect of our health. There are certain times when a person becomes ill, and it's critical to seek a treating professional. So we need a culture that everyone knows that it's smart to take care of our mental health. Being proactive about mental health is just as important as taking care of our physical health. Seeking a mental health professional is a sign of strength, and many are taking that step. And so encouraging people to do that. There are many types of treatment. We need to request a thorough evaluation of what's going on. Because to be honest, some people, when they come in and they're struggling with thoughts of suicide, they often do not disclose that to the mental health provider because they need to get more acclimated to their own feelings. There's psychotherapy, there's medications in the treatment. Research has also shown that many people, the combination of psychotherapy and medication tends to be the most helpful. And that definitely is true. But the most important thing is that they find some treatment that works best for them. And be aware, not all therapists work for everybody. I'm not the best therapist for every single person that I've met with. And so a good therapist will refer them out. And that's the goal, is that we find the best treatment possible.
2 to 5 therapists on average before somebody finds somebody they fit with. So like,
Exactly.
I want to encourage people not to give up hope just because they didn't connect with somebody even as amazing as Jeannie.
Yeah. Well, and sometimes I may not notice that there's a suicide thoughts going on. We're talking about something else, and underneath they are having all these thoughts of suicide, and that's a little scary for the therapist as well. But it's good for the therapist to finally recognize and find out. So good therapist is important, and it's okay to switch therapists. Now, the law does require now that insurance plans do carry or cover mental health services, the same as physical health services. But sometimes it is that we can't find that mental health, but there's always a way to find a mental health provider. Sometimes there's lots of waiting lists, though, unfortunately. So now self-care does strengthen our mental health, just kind of like we go to a doctor for our physical health. We need people to help us with our mental health. In addition to professional health, protective self-care strategies include these on the screen: good sleep habits, exercise, nutrition. Stress management can also play a critical role in protecting mental health and promoting resilience. So be aware of that. Prevention or support for loss survivors and those with lived experience. Oh, prevention efforts with this population is very important. When we're touched by suicide, the loss of suicide to someone profoundly affects many people. It's important that survivors have the support they need both to heal and to reduce their own suicide risk. And since those who have lived experience, those who have attempted suicide or who experience suicidal thinking are at increased risk to think more of suicide. And so we need to make sure they have the support they need too. And one of those preventive factors is we do have a loss survivor support group in Brigham City on the first Thursday of every month at 6 o'clock that Tara and I are there at. Well, Tara's always there. I'm sometimes out of town. And there's also NAMI have support groups and online support groups. So if you know someone who has lost someone to suicide, or you have lost someone to suicide, look for those survivor support groups in your community.
That is a place where AFSP is a wonderful resource as well, as they have many support groups listed online. And I'll remind Jeannie that we are adding a third Thursday in the Tremont area starting this month. So there's also a support group in Tremont as of April, also facilitated by Brigham Suicide Prevention.
So again, for people who are at a crisis point, the most important thing we can do is put between a suicidal person and their way of ending their life is time. Research has shown that by temporarily reducing a suicidal person's access to lethal means, we give the suicidal ideation time. Time for the intense suicidal risk to diminish and time for someone to intervene with mental health support and resources. So for the majority of people who experience a suicidal crisis, if unable to access their chosen method, even temporarily, they are unlikely to engage in another action to end their life. So remember that time is important. Another thing that's important is limiting access to means. When a suicidal person doesn't have current access to the means that they have had on their mind, they don't substitute with another method. So there's a clear way to prevent suicide is to limit access, especially to lethal means like guns and drugs, but there are also other things that we're going to talk about. So we want to limit the access. During a high risk, we want to have it known that the safer the environment, the better chance a suicidal person has of living through that crisis period. Suicide prevention research has looked at a number of ways to create safer environments. So installing an inexpensive carbon monoxide sensor that would automatically shut a car off if carbon monoxide levels reach unsafe levels, that will save lives. We've learned through experience and research that installing barriers on bridges may actually lower the suicide rate for the entire region. And one awesome thing is just this spring is that they finally got the barrier on this Golden Gate Bridge. So that was being planned for a long time. Restricting access to potentially lethal medications reduces suicides and can be as simple as requiring that lethal drugs to be sold in blister packaging. You know, firearm safety, we kind of talked about that. That's critical to reducing suicide rates. Again, like Tara said, firearms are used in roughly half of all suicides, meaning suicide prevention is part of firearm safety. As noted already, contrary to what we think and have thought, that when there's access to lethal means, when they're limited, they usually don't find other means. Therefore, the suicide death does not occur. And that moment allowing more time for the person in crisis to get connected to help. So that gives us more time. It gives the time that we need. So what can you do? Now that we've reviewed key suicide prevention efforts, let's talk about what we can do to prevent suicide. It's important to have a caring, supportive conversation with someone that you may feel that
Sorry, it's
yeah,
going there. It's
yeah.
doing something weird.
I was gonna say,
There we go. Sorry about that.
Mine says have a conversation. So allow them to talk to you. If you have a concern with someone, be okay talking to them. It's okay to ask them, what's going on? I've noticed some changes in you. Are you thinking of suicide? Are you thinking? So, and find out what their level of distress is. What are some of the warning signs? We want to watch for the warning signs in yourself and in others. While many of the suicide risk factors we discussed endure over a longer period of time, warning signs are observable signs that signal suicidal risks in the near future. It's important to pay attention to both the risks factors discussed earlier and the warning signs that we're going to talk about now. If you see warning signs, reach out. Reach out to someone that you might be concerned with, and reach out to help to others that could help. Seek mental health services if you are depressed or if your anxiety regularly interferes with your daily life, and encourage others to do the same. So suicide warning signs are typically displayed in three main areas: talk, behavior, and mood. So let's talk about each one of them. Many people who are suicidal talk about ending their lives. They really do talk about that. It might be a joke. This may be directly or indirectly. A person might say it outright, or they may joke about it, So take that joke seriously. Some people will say that they have no reason to live. Others say things that let you know they may feel trapped, or they are a burden to others, or they might talk about feeling overwhelmed or being in unbearable pain. So these are just little things to be aware of that are not really little. Okay, so behaviors that are typical for an individual should also encourage you to speak to the person when you're noticing that people are thinking about suicide, and they can display certain behaviors. They may have an increased use of alcohol or drugs. They may have trouble with sleep, either experiencing insomnia or sleeping too much. They may start acting more recklessly. They might withdraw from activities, especially from activities they normally enjoy, or they might isolate themselves from family and friends. And they also might look at a way to kill themselves, such as searching online for methods or shopping for a firearm. And they might also give away possessions or show a related behavior like reckless spending. You know, they're spending a lot of money. The other thing on the isolating from family and friends, if they're the type of person that usually does isolate, they don't go to family activities, they don't call very often, and all of a sudden they're showing up at family activities, that's a behavior to be aware of too. And that's a hard one because sometimes we're so excited that they're there that we don't recognize that it might be them having the last time with people. Mood. People at risk for suicide can display, and often quite frequently, the different moods that are on this slide. Depression, apathy, rage, irritability, impulsivity, humiliation, anxiety. Moods are the ones that you would expect someone who feels overwhelmed and depressed. But we all hear of the ups and downs in our mood, but when you notice a change, that's the key, is notice a huge change. And sometimes it's very subtle, but if it's uncharacteristic or concerning to you, it's important to speak to that person about what you're noticing. For example, sudden unexplained happiness can indicate the individual has decided on a plan and is relieved they will no longer be in pain. So again, trust your gut. Assume that you're the one or the only one who's going to say anything. So to sum it up, we need to look for changes in behavior and trust your instincts. Assume you're the only one who's going to reach out. In many instances, people talk about their concern for someone that's, that's in their circle of friends or family, but they hesitate to reach out to the person directly. So here's a rule of thumb. If you're wondering if someone is overly anxious, that's a sure sign you should reach out. And the same goes for you if you're having suicidal thoughts. That's a sure sign you need to seek help. So if you've reached out before, reach out again. The first time the person may not be receptive. They may not get it, in other words. So keep trying to talk to someone else or with a professional. And even if a suicide turns out not to be a concern, they may still be in distress. So sometimes when we ask the question, are you thinking of hurting yourself? Are you thinking of suicide? That can provide comfort for the person, even if they're not thinking that. So if someone asks me if I'm thinking of that, that tells me that they care about me more so than offending, So how to reach out? Reach out to them in public. No. Not a good idea. Talk to them in private. Make sure that you're in private. And listen to their story. Let them talk it through. Express concern and caring. Ask them directly about suicidal thoughts. Are you thinking of ending your life? That's something you should probably practice. While you're in the car, practice saying those words. Are you thinking of ending your life? Are you thinking of suicide? Because it's not in our regular vocabulary. Anyway, it wasn't in mine years ago. But then encourage them to seek mental health services. But if they're in crisis, take them to help or sit with them while they call and get an appointment, or they call one of the numbers that we're going to tell you about. We want to avoid minimizing their feelings. Those of us who have never experienced major depression literally cannot imagine what it feels like. Avoid trying to convince them that life is worth living. We don't want to do that. If person is nearing a crisis point, they are not thinking clearly. Philosophical debates are not appropriate at this time. Avoid advice to fix it. It's kind of like when a person has a heart attack, you're not going to tell them to start exercising and eating correctly. We're going to get them to the hospital. And so sometimes we have to get them to a crisis line or to a mental health professional, listen to their story and offer to help them. Find a health professional for them if you need to. Help them take active steps to get the help that they need. Because when they're in this crisis, again, they're not really thinking well. It's a different thought process. If you think that they are close to attempting, stay with them. Don't leave them. But here's a caveat. If staying with them puts your own safety at risk, leave the area immediately and dial 911. So this would be if they have a gun and they're pointing it at you or they're pointing it at them. Don't try to take the gun away from them because you might be the one that gets killed. So call 911. Help them remove the lethal means or remove themselves from the lethal means or the potentially dangerous area. Escort them to mental health services or to the emergency room. Suicide prevention lifelines are there for all of us. We've got the 988 Suicide and Crisis Lifeline, and it'll give you directions. Press 1 for veterans, 2 for Spanish, and 988 English only. So,
perfect. And you can text, but that's English only.
Yeah, you can text for 988, but it's just an English only one. There are crisis text lines. You can text 741-741. You can text AYUDA to 741-741 Spanish. And the thing to know that a trained crisis counselor is on the crisis text line, and it's free. So, and it's free for you too. Let's see, do we have on the next slide? I'm just looking. Yeah, for emergencies, 911 is a good number to remember. It's okay to call 911. And that we want to make sure if a suicide attempt is in progress, call. So our goal is that we can create a culture that's smart about mental health and suicide prevention. This will save lives and vastly improve the lives of many more people. So just remember that talk does save lives. And if you ever question it, go with their thinking of it. And if they're not, you've at least let them know that you care. So
Okay.
anyway, that's it.
So also though, if you want to fill out this feedback form, AFSP does appreciate feedback on how they can improve the program or things that the presenters can improve as well. And we will send this link, and I will also send the resources that were on that one slide over so that they can be shared with all of you. And Jeannie, did we share the statistics from the CDC already?
You did.
Okay.
But not with me. So if you want to.
Well then,
yeah,
great.
I will.
Yeah, but not.
We will make sure that gets.
We've got that one. We'll get that to you.
Yeah,
Okay.
we'll make sure that gets to you so you can share. And then AFSP is on all social media at the national and also state level. Utah has its own chapter. And then just really quickly, because I know we've run out of time, I want to invite all of you to walk with us to prevent suicide at the AFSP Out of the Darkness Walk in Northern Utah. It's on September 14th at Manaway Reservoir. All the information is at their website or on this QR code. I'll also provide all of that. And then also we are having Matt Townsend. We're really excited at USU Brigham City next month on May 7th. That's a Tuesday evening at 6 p.m. Love to have you. You can register online, and I will also provide this information free of charge. But there will be door prizes, refreshments, definitely going to be a wonderful event. So thank you again for inviting us. We appreciate the opportunity to share this really important program with all of you.
Thank you both, Tara and Jeannie, for that valuable information. I am going to quickly move to our case presentation. Today, I'm really excited to get all of your guys' input. This is a case that I'm actually working on as part of my early intervention hat that I wear. So I work in also in our up to 3 Part C early intervention up here in northern Utah. I am working with this particular family, and it kind of deals with this topic that we had today, as well as our topic last month. And so when we had this, I asked the family if I would be able to share this, because they've been asking me for some of these resources, and I'm at a loss of how to help and support them. So they have a large family. They have 6 kids, and they range from 17 to 2 years of age. I am in seeing the family because of their 2-year-old. Their 2-year-old has some concerns around early indicators of autism. I've been working with the family for about, maybe almost a year on this, and we're working through getting a diagnosis, and so the family has had some stress on that. But in the last 3 months, their 17-year-old has brought up some things to the family that they've been struggling with. And so their 17-year-old recently shared that he is pansexual. Parents are having a big struggle with that. This is a highly religious LDS community, so they or family, not community. I guess a family of 8 is a community in my eyes, but they were struggling with that. So he shared that with them to just kind of see how things would go. And then more recently, he has brought up to the family that he thinks he is identifying as a female. And really, one of the things that both parents are struggling with is how to help the entire family unit. Their 17-year-old, as well as some of the other kids, that they are dealing with some of this stuff. So she does think that she has noticed some behaviors with this child that makes her worried about suicide. One of the other primary areas of concern that this particular family is having is with their youngest daughter. So their youngest daughter has, in the last probably 4 months, has been showing some really high anxiety. And what mom found out just recently is that the 17-year-old has been sharing this information with this daughter before sharing it with the family or other individuals in that. So this the younger daughter feels responsible for some of this. This 17-year-old that is dealing with this is also has some friends that have convinced this person that their family is going to kick them out because of all of this. When in all reality, that mom has reported that would never have happened. She has felt like she has been very supportive of all of this, especially even when he came out as pansexual. So the parents are really overwhelmed. So I am in there again to help support this little 2-year-old, but because of everything that is going on with the family unit, mom's not able to really focus on this 2-year-old that is dealing with some high indicators of autism. And I think that's always what this case is brought to my attention, is that especially for early intervention, we're in there to support the whole family. And I can't really work on addressing some of the things that might help this 2-year-old when all of this is going around with the family, that they're stressed about a whole variety of other things. But right now it's out of like my realm. I want to be able to support this family and give them those resources, but I don't know what to do. So I would love some ideas of how would you, as either an early childhood provider or whatever discipline you're in, support the family with these concerns. And then what resources or things can the family reach out to for entire family support, not just individual support? And then how do I continue to encourage the family to work on those early intervention strategies? Because if we don't start working on some of those early intervention strategies, the family is going to have a whole lot more stress because of some of the behaviors and things that their 2-year-old is doing. So those are our questions. I think that Shayna has put them into chat with that. So I'm going to just go briefly through the hub members who are in the breakout groups. So JC, you are going to be tackling the question of what would you, as an early childhood provider or anybody else, support the family with these concerns. And then Jennifer Morgan, if your group will take what supports can the family reach out to, or resources could we provide the family? And then Kurt and Heather, you're both in a group together, and how do you try to encourage the family to still work on early intervention strategies? So again, during those breakout groups, if you'll take a minute and introduce yourself, and then kind of try tackling those questions. And Shayna will put us into breakout groups, and we will come back at 1:25.